Our next speaker, keeping with the theme of understanding the epidemiology and global risk factors, is Dr. Kyu-Pyo Kim from the ASAN Medical Center in Korea. He will be talking about the practice patterns and outcomes from real-world cholangiocarcinoma outcomes. His group has published and is really considered an expert in telling us what's happening with patients in Asia with this disease. Welcome.
Thank you for the introduction and for the invitation really to this meeting. Stacy and Katie really organizing all this. Today I'll talk about the situation in Korea actually and what our real world data was based on that. So let's see if I could get, wrong one. This one. Oh, this is the laser. Yeah. Oh, sorry. Okay. So definitely during the first two talks, everyone's now an expert on what really bile duct cancers are, gallbladder, the intrahepatics, the extrahepatics. And sometimes really if you look at the data, scrutinize it, you can also see some ampullary data within that, within the literature. But even if it is divided on these anatomies, really it's, as Dr. Hernandez just presented, really various etiologies. And according to these various etiologies, you can also see different histology patterns and actually genomic profile and other biologic and clinical courses often differ according to the locations and etiologies. This slide was also touched upon. Korea, as you can see, is within the red area together with China and Thailand and the Asian areas that cholangiocarcinoma is quite endemic within. Actually, this slide was talked about definitely intensively, but I just wanted to point out that really while a lot of the Western countries were based on primary sclerosing cholangitis, which we always call PSC, more and more Asian countries are more about the stones, the bile duct stones, cholangiocarcinoma or calorie disease that occur with biliary tract malformations, the liver fluke infections, and also as the Asian areas are quite endemic within the Hep B and Hep C hepatitis viruses, I think that is the cause of this difference in geography. Actually, even in Korea, it's a small country around, so this is only the south part of Korea, and that would be around half the size of Florida. You can see that on the left, you have the male prevalence, and on the right, you have the female prevalence. And even in that slide, you can easily see that around in the south east area, there's this more dense area. And actually, the reason for that was due to the liver fluke. So why that happens is, actually there's a river that flows through this area, and that river itself has some really tasty fish, and everyone tastes that. Because of the people that have that fish, they consume it, they get exposed to the liver fluke that lives within that fish. Often we tell people don't eat the fish, but they'll just eat it and have their, actually there are families that have their annual meetings to have the praziquantel that would be the cure for these flukes. So despite we telling them that it's not good, it is quite, I've tasted it myself too, but it is quite good. So everyone definitely just loves to get that fish. But anyways, due to that reason, really you can you see a very high incidence of cholangiocarcinoma, CS. So CS infection, you have a very high rate in this area that matched with the high risk of cholangiocarcinoma within that area. Actually, another part, as was talked about, the underlying cirrhosis and the effect of having a liver disease on cholangiocarcinoma, actually it also has an impact on the histology itself. This was a paper we did together with our Japanese colleagues, and really, as you can see, the left and the right are definitely different. You can see that these, they're called lumens, so you can see the lumens, while on this side, you can't see those kinds of lumens, and they're all mushed together with the surrounding liver. So oftenly, if you have underlying liver diseases, you have a more bile ductular type of cholangiocarcinoma, while the other types are without an underlying liver disease, you'll just see a normal cholangiocarcinoma with the bile duct type. Another part is here you can see these various lumens, and we call them papillary formations, but really with the mucinous type cancers, you often see these intraductal papillary type neoplasms. So actually not only is it different in etiology, but actually in the histology itself, you can see those kinds of differences. So bile duct cancer, it's quite challenging to cure oftenly because it's really a multidisciplinary event. Oftenly patients are most suffering from cholangitis and all these anatomical problems that occur around the pancreatobiliary area. And really that's why you have to need specialties from really various groups. I put this slide up. This actually was done 3 weeks ago, and this was done around a year ago. It was 2 different patients, but this was a very intriguing case because I'm not sure if you can see it right from far away, but really you can see this patient undertook 4 biliary tract stents. So during the course of treatment, really our GI people really helped us stent all these entities out. The malignant strictures that really cause the death of patients that would induce cholangitis. And really with these specialties, we often think it's often noted with pancreatic cancer too that these high volume centers are more, you see a more better outcome because really the specialties there really help us out on really going through all these extra stentings or extra interventions that really help the patients survive these events. And even in this slide, actually, we're now going into RF ablation. So even for these strictures, you can ablate these lesions out so that really it helps patients not have to go to the ER every time there's a slight fever or jaundice. So these kinds of activities are, I think, very much increasing. So if we go into the database, actually, this was actually the era before the database, and we started to see all these patients, and we were trying to cut out which was better, which was worst. And this was really this slide, these 2 slides were really a multidisciplinary effort, but what they pinned out was actually that at that time you could see that intrahepatic had a more worse prognosis, and the initially advanced disease, so metastatic disease, it would have a worse prognosis. So it did match what we thought. And then we went on to see really how chemotherapy had its effect on the disease itself. And really on the left, you can see the well-noted, the ABC02 trial, and the right was the data extracted from our database, and you could see that it did match quite similar with a PFS around 5 to 6 months and an overall survival around 10 to 12 months. So they did so this was done in the UK and this was done in Korea, so you can see that despite the geographic differences, the prognoses were quite similar. And then actually this is an effort we did last year, and the next question we also had was really for chemotherapy, how long are you going to do chemotherapy? Oftenly, a lot of because the regimen does include platinum, really patients do get tired of platinum. And we wanted to see if really we could give a holiday for this, and if we're going to maintain the chemotherapy just continuously after 6 months or really have our holidays. So with this slide for the observation group, we just scheduled the chemotherapies for 6 to 8 cycles. And for the maintenance group, we just kept on doing chemotherapy until toxicity would allow. So, and really we could see that there wasn't quite much of a difference between the two groups. So I think it is quite similar to the lung cancer situation, that also you can see that you can do a scheduled amount of chemotherapies and go on to a holiday. And this helped us out. And the next slide actually was about second-line chemotherapy. So for even second-line therapy, what is the role for chemotherapy? And I'm not sure if you can see from the back, but it was fluoridine, so 5-FU alone versus 5-FU plus a platinum, FOLFOX, or Xeluda plus cisplatin, and really, we didn't see much of a difference. So really, even after being exposed to your first-line platinum, is there really a big role for the second-line platinum? And we, from our database, we didn't think that there was much of a role for that second-line platinum, and it was only a really tiresome thing for the patients. So from the database, we thought that really it did extract quite good information on really how long are you really going to do the chemotherapy, and even for second-line therapy, what are you going to do for it, and how much are you going to really have to endure, or can you get away with more holidays and really more rest rather than more chemotherapy? There are other modalities too. So for local modalities, we also did a study with photodynamic therapy. It's with the endoscope, you put in a probe that really delivers a photodynamic luminant probe that goes inside the tract that really would, it doesn't go, the depth isn't that high, but really, it really is good with the strictures. So you can get less cholangitis. And this study was actually, if we're going to go for local therapy alone versus local therapy plus a chemotherapeutic agent, that was TS1. TS1 is a drug that is usually used in the Asian areas, that was made in Japan. And really, even in this slide, we could see that adding a chemotherapeutic agent with PDT really helped us out more. Presently, there is a study going on that does gemcitabine plus cisplatin plus PDT versus GEMCIS alone. So I think everyone's looking for the results of that trial that we expect in the coming years. The next slide was about TACE. So in liver cancer, a lot of people will do treatments that are called TACE. It's transarterial chemoembolization. And what the story is as you can see on the left, some of the cancers have more arterial enhanced. You can see the more, it gets more whiter in this phase while it washes out in this phase. So we often call it an arterial enhanced with a venous washout, and it's often seen within liver cancer. But some patients, especially the patients with underlying liver diseases, the cholangiocarcinoma itself also shows similar patterns. So we thought that really if there was a role for this, and you can see the arterial enhance on embolization, the angiography that we did embolize. And really, you can see a very high response rate because actually it's not systemic chemotherapy, so it itself will have a very devastating local effect. But actually, it is quite, I would say roughly around maybe 10% of the patients will really show this kind of pattern. So it's not for every patient, but really if you select the right patients with the right arterial enhanced patterns, there are patients that really can benefit out of this. And you can see that it did translate to an overall survival. But really, it is hard to do a trial with these kinds of patients because the pattern itself is quite hard to define. It's very hard to put it into a trial because it's very hard to define. So, but I think that really, if you have the right situation and if it is in the right context, it does have a role. So that, I think, will end my talk. And definitely what I just wanted to say was that cholangiocarcinoma is similar between the East and the West. Although the Eastern Asia area does have a higher prevalence of liver flukes and chronic liver disease that does translate to cholangiocarcinoma. I think the effort itself is very similar, and that we could learn from each other really by these real-world data and trials that we could do together. Thank you very much.